Hi everyone, welcome. So we will get started so that we can take full advantage of our time here, and this will be recorded. So folks who come in a little bit later will get a chance to jump in and to get the full experience. So first and foremost, welcome everyone. My name is Dr. Kamal Jones. I am pediatrician and the policy and legislative affairs analyst for our AAP California Chapter 2. I have the distinct privilege to say thank you for coming out this evening and for attending today's webinar entitled Everybody Deserves Healthcare, No Child is an Island. Where we'll be focused on universal healthcare. Today we have the incomparable Dr. Bob Vinetz. Bob is a now retired pediatrician and member of the Academy. Bob trained at USC Med School and completed his residency at County USC. Dr. Vinetz became active in the Academy in the late 70s, early 80s, when AAP began their Speak Up for Children program. Bob was involved heavily with the launch of the auto safety initiatives at that time, including testifying before the United States Senate and helping to get the law changed to mandate airbags to be placed into cars, and being involved in a host of other national advocacy work with the Academy, for which he was awarded for his efforts in the 80s by the Academy. After a beautiful 45-year career practicing pediatrics and 3 years in public health in LA County, caring mostly for low-income, minoritized patients, Spanish-speaking patients, Bob retired in 2018, very wisely dodging the pandemic. But Bob is still someone who's active in his advocacy efforts and focuses. And so we are honored to have Dr. Bob Vinetz here today, who's going to talk to us about healthcare financing and how we can create a more fair, just healthcare system. Welcome, Bob.
Yeah, hi, Kamal. Kamal, thank you so much for that introduction. And both to you and the Academy of Pediatrics California Chapter 2 for really the honor of making this presentation. And thanks to all of you, colleagues. I see some family and friends also for joining us this evening. I really hope it, will be informative for you and everybody else. What we'll be talking about today is universal healthcare and trying to better understand aspects of it, both, the inadequacies and the harms caused by our current financing system, but also how universal, affordable, equitable healthcare can be achieved. It really can be through a not-for-profit unified system of public financing. I think you'll see recurring themes kind of threading through this presentation today, which include the no child is an island, upstream, downstream idea, and something called better is possible, which we'll get into later. A heads up, my presentation will take about an hour with a Q&A after that. I hope you'll be able to stay with us, but if not, I'm told you'll be able to view the entire webinar later online as I think a podcast. Next slide, please. This is a video. It's a true story of Fumiko Chino. You want to play it now, Kamal?
Kamal, you may have to share your audio real quick.
12 years
Yeah.
ago, I had my dream job as an art director in Houston. My fiance, Andrew, was finishing his doctorate in robotics. The future stretched out forever in front of us. When he started to vomit and lose weight, we were blindsided. But we were young, otherwise healthy, and both had health insurance. We never imagined what was to come. He was diagnosed with neuroendocrine cancer, and we quickly discovered how little his insurance covered. Within a month, we had exhausted his annual prescription drug benefit and started paying out of pocket. Despite his cancer and our empty pockets, we got married and tried to keep moving forward with our lives. After a ceremony in my parents' living room, we headed to an Italian chain restaurant. Meanwhile, the steady floodwaters of tests, treatments, and bills continued to rise. Soon, we had passed his health insurance's $500,000 lifetime limit. I emptied my retirement savings, but bills kept crashing over us week after week, threatening to drag us under. We borrowed money and at one point had families smuggle low-cost medications across the border from Canada. Even with our safety net, we were struggling. Just when our fall into financial ruin seemed hopelessly guaranteed, Andrew managed to get a faculty job in Michigan with health insurance. Cancer took him only 3 months after we arrived in Michigan, and a lifetime too soon. Andrew was gone, but the bills were not. The storm clouds of his medical debt still haunted me. Collectors were relentless, even calling my cell at his funeral.
Yeah. Even calling his cell at my funeral. This is a true story, actually, of Fumiko Chino. Fumiko is currently, has become a physician, is now a cancer specialist at Sloan Kettering in New York. Her story was published actually as a comic strip, full page in the Los Angeles Times several years ago. It illustrates for us the harms, the injustices, the financial, impoverishment almost that's caused by our healthcare financing system. And this leads me to a parable. Next slide, please. It's the upstream, downstream parable, which many folks in public health like to use, but it applies to what we're talking about also today. I'll take a whack at it. Once upon a time in a land not so far away, people of the village used to gather by the stream, to talk, to socialize, to see the kids, to compare food and recipes, to swim in the river, just, to have a good time. One day, though, suddenly one of the women looked out at the river and screamed. She saw a little child clutching a log floating down the stream, believing, I think correctly, that the child couldn't swim and was at grave risk. She dove into the water, swam out to the child, and hauled the little one back to the shore, dried him off, fed him, cuddled him, and things were okay. But people were terrified, but hugely relieved, by what had happened. But a few minutes later, same thing. Another child was seen clutching probably a door or a branch or something going down the stream. Somebody saw the child, screamed, swam in, pulled him to the shore again, and same thing happened. Kind of worrisome. But a few minutes later, same thing. And then a few minutes after that, again and again and again. The people were just overwhelmed trying to pull these kids out of the river. Suddenly, one of the actually women started to run upstream. The others, just were mortified. What are you doing? Where are you going? Why we have to pull these kids out? She said, I'm going upstream to try and figure out why all these kids are floating downstream now. Well, parables do help us understand things. Next slide, please. Well, why look at financing? Well, because financing is upstream from virtually everything in pediatrics, everything in healthcare. For-profit commercial financing drains money and other resources away from healthcare and other societal needs. It causes harm to kids, families, pediatricians, everyone. And actually virtually every aspect of society. Fumiko's story and the parable actually help us to understand on a visceral level that our healthcare system is broken, that there are downstream harms caused by the way it's financed. But they also call us to envision ways to see that, another theme, better is possible. Next slide, please. So what are the harms produced by, produced downstream by our financing system? Well, here's the list. It's a partial list. I'll read a few of them that are, caused by our current system. Cost, obviously, highest in the world. Uninsured, 28 million people. Underinsured, 40 plus million. Preventable deaths, 28,000 every year. Obviously makes getting care harder and it worsens health, pain and suffering, financial, undermining social trust, functioning and confidence even in democracy, labor-employer conflicts, economic competitiveness is impaired because there's a lot of monopolies going on here, and it drains money away from other societal needs. Let's dive a bit deeper into some of these harms, starting with cost. This is a complex slide, so I'm going to try and go through this piece by piece, because I think it's important to do that. You'll notice that this is public spending per capita for healthcare. The total in the US, public spending, compared with other wealthy countries is, to me at least, and I think to most people, really astonishing and sad. The US total spending on healthcare is over $13,000. And this was actually back, I think, in 2020, I believe these figures are from. If we look at other countries, such as Japan, the UK, France, Canada, Holland, Sweden, Switzerland, Germany, other high-income developed countries with excellent healthcare, virtually all of these countries spend in most cases, less than half of what the United States spends, and they provide universal health care. The public spending alone in the United States, the bottom line here is $8,500 a couple of years ago. In order to finance what the public doesn't finance, people have to pay out of their pocket an extra $4,500, coming to a total of $13,300 on average per person in the United States to pay for the health care that we have, which many actually don't get. American taxpayers, through public taxes, already pay more than people in nations with universal health care. Next slide, please. So we've seen this slide before, but I don't want to focus so much on, the difference between Canada and the United States, but on what Canada did here. You'll notice that when Canada introduced their universal healthcare system in the early 1970s, they were able to control the rate of rising costs of healthcare, and the US hasn't. That's a big deal. Next slide. So, let's take another look at this list of harms. The items here in red we'll look at now: the underinsured, the uninsured, and preventable deaths. Next slide, please. So, whoops. Americans uninsured all year. This is from 1976 up to 2021. Way back in 1976, was I in med school then? No, I was out practicing for a few years. 18 million people were uninsured in the country. And that number rose steadily up to about 40 million in 2010. And then guess what happened? The Affordable Care Act came in, which absolutely terrified so many people. What it actually did, though, in real terms, is it precipitously dropped the rate of uninsurance, or the percent of uninsured people, from about 40 million down to roughly 25 million. Big drop, huge deal. That was due to Obamacare. Next slide, please. But it doesn't end with uninsurance. The downstream consequences of uninsurance aren't just impeding care, worsening health and financial problems, but also causing deaths. Research study published in the American Journal of Public Health in 2009 showed that for every 1 million insured people up here, 1,000 people unnecessarily, prematurely die every year. So in 2019, with 28,000 uninsured, it's about the same now, that comes to 28,000 unnecessary premature deaths every year from uninsurance. The downstream consequences of uninsurance are, really sad. Next slide, please. Let's take a look at underinsurance. The definition of underinsurance is vulnerability among working age adults in the ability to afford coverage and get the care and medication that they need. There are very clear criteria for this. which relate mostly to out-of-pocket costs, such as deductibles, co-pays, and so on, and also individuals' income levels or family income levels. The downstream consequences we've already looked at. Next slide, please. Uninsured with and the underinsured. Underinsured in the first 6 months only of 2020, 24.2 million. The underinsured, about almost 60 million people. The total was over 83 million people inadequately insured. Next slide, please. This looks at the rate of uninsured or underinsured, excuse me, among people who actually have insurance. This is data from 2022 for adults. What I want to point out here is that the underinsurance rates are not equally distributed among income levels. If we look at the two middle bars, folks or families are earning between 134% of poverty and almost 400% of poverty. The middle class are 70% of people who are underinsured. 70% of the US population is underinsured, including those with insurance, private insurance, insurance through, your work, whatever. A lot of those adults are parents. Again, coming back to a theme, no child is an island, because a lot of those parents can't afford healthcare and have to use their money for food, for rent, for other stuff. Next slide. Pain and suffering and unnecessary deaths. Little theme I often use in my emails. Mom died at age 39, so 5-year-old Mason became motherless. Again, a running theme, no child is an island, even if the child has insurance. Next slide. So we're now at harms produced downstream again, this wonderful list. At the bottom, drains money away from other vital social needs. What this basically tells me, and I think a lot of other people, is that our healthcare financing system is toxic to all of our society. It drains money away from other vital societal needs. Let's take a look at a few of those. Next slide. So the current financing system drains money away from addressing racism, injustice, and inequities, which are huge and urgent problems, even crisis level problems, impaired by healthcare financing. And a ton of other critical public, needs on this list, which include, among other things, healthcare, schools, fire departments, public safety, housing, transportation, pollution, climate crisis, and on and on and on. Next slide. Here's just an example of something that happened in 2008 when California was looking to establish a universal healthcare single payer kind of system through legislative means. And a study was done projecting the costs of what LA Unified would save from that single payer system. This is in 2008 and 2009. The study showed that LA Unified School District would save $300,870,000 a year on paying for health insurance for employees, for teachers, and for other folks working in the system, in the education system. 600,000 kids in that system, by the way. Anyway, that was back in 2008. Imagine what it would be now. Double that, probably a lot more. We could figure it out if we wanted to make some calculations. If we had that system today, just imagine what could be saved and including and used to reduce class size, pay teachers what they deserve, better facilities, blah, blah, blah. Next slide, please. So one of the things that I want to look at is a root cause of the high cost of our healthcare system. A root cause of why our healthcare system costs so much. Well, let's take a look here. And I think this will probably ring true with a lot of you. We're looking at the growth of the number of physicians compared with the number of administrators in the healthcare system. Going back to 1970, pretty eeky low. Physicians are in yellow, the managers, administrators, are in this kind of greenish turquoise color. You can see that the number of physicians barely rose at all compared with the percentage of administration. Administration increased 4,000% from 1970. A lot of administrators and managers and folks in our system. When there were very few in 1970, imagine all of them, and we see them where they're hidden behind desks or another building every day in 2022. It skyrocketed administration and administrative costs. Next slide, please. An example of this, actually close to home, is the number of billing clerks. Long Beach Memorial Medical Center and Miller Children's and Women's Hospital here in Long Beach, California, just right outside of Los Angeles. Those two hospitals have a bit over 800 beds. The number of billing clerks I've calculated from other estimates on average in other places around the country. Long Beach Memorial and Children's there, 1,300 billing clerks for 1.7 beds per clerk. Costs a lot of money. Close to home. Next slide, please. One of the places I got comparison information from was the Duke Health system, not just the hospital, but an extensive system, kind of like UCLA is here, not just hospital, but Duke Health is in North Carolina. And for those billing clerks and the billing system, Duke's costs to send bills for one ECP, one physician, in their clinics or wherever, $99,000 a year. This was published in JAMA in 2018. Right now, it's more. Next slide. So if we look at the administrative costs of healthcare in the United States and Canada, again, 2017, we've kind of looked a little bit at this. I want to refresh. U.S. insurers and providers spent $812 billion on administration alone in 2017. Per capita, about 2,500 per person. In the US, 550, or so for Canada. US, 34% of all national healthcare expenditures, that versus 17% nationally for Canada. These are some of the absolute cost numbers due to that bloated administration. Again, better is possible. Just look at the comparison between the US and Canada. Next slide, please. It tells us, again, if the US had a payment system similar to Canada's or other wealthy nations, most, but not all in Europe, basically we're already paying for universal health care, but we're just not getting it. We could have it. A lot of people refer to this as universal health care, everybody in, nobody out. Wouldn't that be nice? Yeah, for me. Now, the next slide, it kind of sums it up. Better is possible. Looking at the slide, we see over here on the right, insurance and administrative overhead for the US system extracts 34 cents out of every healthcare dollar for overhead. But clinical care, we get 66 cents out of the dollar. This is why focusing on healthcare financing is so important. Next slide, please. Again, looking upstream. There's another crucial and too often invisible, underappreciated reason why our healthcare system causes so much harm. Next slide, please. This is a video.
1978, I was on overnight duty in the pediatric emergency room at Los Angeles County Hospital. It had been a busy night, and I was looking forward to the end of the shift. At about 4 a.m., a man with a frantic expression came rushing into the ER, carrying what looked like a small log wrapped in a blanket. His 4-year-old son had suffered an asthma attack, and the man had bypassed several private hospital ERs on the way to the public hospital. He'd previously been refused emergency care at the private hospitals due to lack of insurance. On this occasion, the father did not want to waste time and took the much longer drive to Big County. I took the bundle from his arms and rushed into the treatment room. As soon as I unwrapped the child, I could tell that he had died en route. I tried to resuscitate him, but to no avail. I informed the father that his son had died, and he responded as one might expect. Sometime later, as I was standing outside the ER, watching the son come up and trying to make sense of what had happened, the father stepped outside too. I stammered an apology for not being able to save his son. He said, "It's okay, Doc. It's not your fault. His father is a poor man."
Next slide, please. It's okay, Doc. It's not your fault. His father is a poor man. Next slide, please. Racism, poverty, injustice themselves cause harm. This, of course, was pointed out by many people. It's still true. One of the most poignant expressions of this, I think, was by Martin Luther King in March of 1966. Of all the forms of inequality, MLK said, injustice in healthcare is the most shocking and inhumane. Next slide. The This next slide asks a very pregnant question. Why are those harms happening? What's upstream from them? Well, those things are happening because of values. Values upstream from the source of our system. As a principle, values determine what is valued. Value is based on values. Value comes from, is mothered by, is fathered by, is parented by values and the system. When value-based arguments are made for anything, it's important to ask, on what values is that value-based? Well, let's take a look at the values part of this. Next slide, please. In the United States and in most of the world, there are two value systems which are mixed and compete with each other. Let's study this slide a bit now. Those two systems include the commercial, market-based, profit-based value system, which dominate. In this system, profit is first, service, care is secondary, versus the public commons or service social equity-based value system. Here, service is first. Profit is secondary, if at all. And what does this lead to, this dominance and this competition between the two systems? It leads to complex, inefficient, expensive, multi-payer mixture of public and commercial payers in the United States. Graphically, that looks something like this. Inside of all this complexity, let's tease out a few of the mechanisms that are used to make profit. I do want to add, though, before we leave this image, that I show this diagram not because I think it's accurate necessarily, but because it visually captures the truth of the kind of unfathomable complexity of our healthcare system now. Okay, next slide, please. So what are the mechanisms that are used to maximize profit? What are they? Well, one of them is something called the charge master. And I don't know if all of you have heard the term charge master. What it is a database in companies, systems, wherever. It's a database of items that are billed. And the way it functions is it works by paying or charging different amounts for the same service or item. In other words, what it does is it unlinks any relationship between charge, price, which is price paid, and cost. It unlinks them. Here, the Cleveland Clinic's above charge master is instructive. The number of prices that the Cleveland Clinic's charge master has is 210 million different prices, none of them related to cost or anything else. They just put a number on it and charge it. Next. So let's take a concrete look at this. And this actually was an article published in 2021 by the American Academy of Pediatrics hospital practice in the journal. Charge versus price paid versus cost of charge masters. The study looked at 847 hospitals throughout the country in 2021. Of those, a number were children's hospitals in 6 metropolitan areas, and what the range of charges of those hospitals were for the same item. The cost or the charge for CBC, for example, varied from $5 up to $1,885 for a CBC. For a CMP, complete metabolic panel, prices range from $6 up to, hold your breath, $2,746. Please. For a chest X-ray to see through things. $30 with a charge ranged up to $5,800. Hold your breath or don't. There is no relationship and a huge variability between charge, price, paid, and cost. Let's look at another mechanism for maximizing profit. This is a very colorful one. And I do love cherries, especially if they're chocolate covered. But one of the techniques here is cherry picking by insurance companies and others. They're looking for a way to select low-cost patients, such as, next slide, these young people who are vigorous, active, young, and very low cost and, surprise, very profitable to people who insure them and care for them. And there's another way that costs are controlled, and that is by what you're seeing now, this lemon dropping. Lemon dropping works by a little technique called, next line, risk pooling, dropping lemons into risk pools. I'll go over the slide in a second, but I want to just point out or say that many things, not just medical conditions, are lemons and can function as pre-existing conditions shown in this slide. We'll go to the slide now. Avoiding high-cost patients by risk pooling. And here, this gentleman is explaining to these patients and people who are looking to buy health care and get health services. He tells them that pre-existing conditions get placed in high-risk pools. Well, let's take a look at the pools. Over here, the pool with the diving board happens to have alligators in it. Not a low-risk pool if you swim in it. This other pool, of course, here has quite a few sharks swimming around in it, probably great white sharks, most likely, but could be any kind. Anyway, so if we look at risk pools and want to put high-risk patients out of the low-risk pool, that would include pre-existing conditions such as the likelihood of becoming pregnant, living in a zip code of low-income people or people of color, where anything that increases the risk, the possibility of high cost and reducing profit can often be used to put them in a high-risk pool. Hello, alligators and sharks. And attempt to avoid insuring or providing care or services to them, avoiding them entirely. Kind of reminds me of something called segregation. Next slide. But upstream from all these very important and powerful profit-making mechanisms are bigger fish. Wall Street mega corporations see a gold mine in the some $4 trillion US healthcare sector. They're mining it. They're mining that multi-trillion-dollar pool by monopolization, and monopolization for profit, for money, not for care. Some of you know about Willie Sutton, a very charming, famous bank robber in the 1930s. And he was asked by a reporter once, well, why do you rob banks? And Willie is said to have answered, because that's where the money is. Well, here we have mega controllers of the US healthcare system. There they are. But further, I want to emphasize here that I do believe there is a place for profit. However, usually not extractive profits that cause harm. And especially not extractive profits in healthcare or other services that are needed for the public good and the well-being of all of us. Next slide, please. So how do other developed nations do what the US doesn't? Next slide. Well, I think we've seen these slides before, but I want to point out something here as we go. You want to hit the first line, please? National Health Service, United Kingdom, New Zealand, Italy, public funding, public delivery, socialized medicine. I'm not sure if I've been over this before, but I'll do it again because it's important. Next one. National health insurance, Canada, Spain, Ireland, Austria, public funding, private delivery. Similar to, Medicare for all, single payer, Canada, whatever. Bismarck, Switzerland, all payer systems, Switzerland, Germany, France, so on. Mixed funding, private and public funding, but private delivery, as well as some public delivery. Highly regulated nonprofit insurers. And down here, we look at the next one, the wonderful multi-payer system. We have mixed funding and mixed delivery here in the United States. Next slide, please. Can somebody tell me if we're repeating this? I've been over this so many times, I can't remember if I've done it in rehearsal or doing this.
Nope, this is first time.
First time. Oh, good. Gosh. At 81 years of age, I guess I can't be faulted for some lapses in memory. Anyway, let's look at many better choices of healthcare system types. Kamal, you want to hit this? Well, the first one is socialized medicine. A horrible term, but it works pretty well in the United Kingdom, New Zealand, Italy. It's 70% less expensive than we have in the United States. The other results in those countries are, for the most part, excellent. The next method of financing, national health insurance, Canada, Australia, Ireland, Spain. It's like Medicare for all in Canada, single payer, terrible terms, 50% less expensive than what we have now in the United States. Other results, pretty darn good. Next one, the old Bismarck all-payer system, like the ACA and Obamacare, but on steroids. 40% less expensive than what we have in the US. Other results in those countries, superb. For the most part, nothing is perfect anywhere. Finally, the United States, multi-payer system. It's the most expensive. We have the most uninsured, for developed nations, and the shortest life expectancy of developed nations. Because of our healthcare financing system, we could have all of these, any of these others would be better than what we've got. Next slide. So I think we've looked at this slide before. I don't want to belabor it, but basically to reiterate, it shows that on average, the US pays $13,000 or more per person on average for healthcare, more than double what almost all of the other developed countries pay. And those nations have universal healthcare. In the following slide, let's take a look at Canada's costs and how Canada controls them. Basically, I'm showing this slide again, not to go over it, but to lead into the next slide, which shows, how Canada controls that rise in costs. And these are the ways they do it. I'm not going to go over all of them, but one of them is public not-for-profit financing, low administrative costs, doing what it's needed there, lump sum global budgets for hospitals, stringent controls on capital spending, emphasis on primary care, hello, pediatricians, and the exclusion of private insurers for services that are covered by the universal healthcare system. So if you want to have, a facelift because you've got a few wrinkles, you can get private insurance and they'll pay some of it, but you'll pay it. Next slide. So I think we've been through this before, but I'm going to quickly go over it again. The US pays $812 billion on administration. Per capita, about $2,500, compared for $550 or so in Canada. The takeaway from this, if the US had a payment system, I think, like I've already said, similar to Canada's, not necessarily the same, the US could save over $600 billion every year and redirect that money to healthcare services and finance 100% of universal healthcare for everybody. And what I'm presenting now is evidence-based, as the next slide shows. A research study, a systematic literature review of 22 economic analyses on the projected cost of a single-payer, healthcare financing system was done and published in PLOS Medicine in January 15, 2020, peer-reviewed. What it showed was that out of these 22 analyses, 86% of those analyses showed that there would be savings from that system in year one, in the first year. 91% of those studies showed that there would be savings over several years. I don't know, 3, 4, 5 years. Long term, it showed that 100% of those studies would produce savings for the system. And the greatest source of those savings, surprise, administrative costs and drug costs. Let's take a look now at a few things as we wind toward the end of this talk. We want to look at values and attributes of an optimal system for healthcare financing. Then we'll take a look at what's happening at the federal and California governmental levels, and then look at what's happening in a few medical society activities around the country. Next slide. Now, this is really important, so I'm going to kind of tiptoe through this. And what I want to lead into it with is that more important than our health, than what our healthcare system is called, are the essential values and attributes that are embodied in any system. So whether it's called a better U.S. healthcare system for all, improved Medicare for all, single payer, a unified system of public financing of universal healthcare, et cetera, whatever you want to call it, we would want it to embody certain values and attributes, like shown in this complex slide. So let me just run down a few of these attributes that the optimal, the first column, most of us would like to have. We want everyone covered. We want lifetime coverage. We want all medically necessary care guaranteed. We want free choice of doctors and other providers of hospitals. We want care, not profit, to be the top priority. We want copays and deductibles, out-of-pocket costs eliminated. We want bankruptcy from illness or injury eliminated. We want uninsurance eliminated. We want underinsurance and cost sharing eliminated. We want the cost for the system to be controlled and sustainable, like Canada. We want waste and inefficiency, administrative overhead minimized, controlled. The optimal system has all of those. On the right column, national health insurance, like we've been talking about, various kinds, has all of these, meets all these, incorporates all these values, and has all of these attributes. The market-based system that we currently have in our country achieves none of them. The very helpful for some people, affordable health care, Obamacare, unfortunately doesn't achieve any of those optimal values and attributes. Let's go to the next slide. So we've been over this a little bit. I'm going to recap quickly the mechanisms for achieving those target values and attributes in health insurance. Public funding, 100%. Everything is covered by the plan, not for profit. A single risk pool. If a system has multiple risk pools, somebody's gaming it, and you're paying more, or somebody's paying more for it. Global budgets for hospitals, negotiated drug and device pricing, minimizing bureaucratic waste, and redirecting whatever savings exist to cover everyone. Next slide, please. So what's happening at the federal and California government levels? Next. Well, just last week, May 17, 2023, bills were introduced into both the U.S. Senate and House. Both of them were called the Medicare for All Act of 2023. The authors were surprised, Bernie Sanders in the Senate and Representatives Pramila Jayapal, I think Washington, and Debbie Dingell from Michigan. Their aim in these bills: universal coverage, single public paid plan, comprehensive acute and other benefits, no copays for covered services, bans duplicative private practice. It's okay to have, facelift surgery, cosmetic, drug formulary, and price negotiations. Well, will these bills pass before 2025? Heck no. But what these bills will do is promote discussion. It'll help educate the public and legislators all over the country about how and that better is possible. Next slide. California. This is a pretty thin slide in terms of what we're doing. It could be definitely expanded, but let me go over a few things. Something called Golden State Care. It's a proposal and a roadmap for a California-specific model of a publicly financed, not-for-profit healthcare system. It's being advanced by the California Physicians Alliance, CAPA, group of physicians and other advocates trying to get a publicly funded universal not-for-profit healthcare system. Also, Healthy California for All Commission report, which was conducted and finished, I think, late last year. It was commissioned by Governor Newsom. The commission held multiple meetings, a lot of search of evidence, gave the report at the end of 2022, sent it to the governor, and it had several things that happened from it. One of them is the governor caused the formation of a California Healthcare Affordability Office. I think I've got the right name for that, the right title. If not, I'll correct it later. But there is an office looking at that. They don't have any regulatory control, but they're going to be able to study it very, very carefully from a California-only perspective. There are also several other bills pending in the legislature of California. Next slide. So some medical society activities. Next slide after that. Okay, next slide here shows the American Academy of Pediatrics, AAP, and healthcare financing. The AAP has a number of policy positions. They have a terrific office. We have a terrific office in Washington, D.C., doing advocacy at the federal level. The Academy has an annual leadership conference every year. A number of them I've submitted resolutions to. But in 2021, a resolution number 15 was submitted by a former chair of the Committee on Child Health Financing, Mark Hudak, focusing on Medicaid reform. And it passed. It was the number one top priority recommendation to the board of the AAP, that the AAP executive board look at and do something with. What they did is they looked at it. I think they're still talking about it, I hope, but they sent it to the Committee on Child Health Financing, which is now promoting a major focus on foundational reform for Medicaid. Why? Because I think it's about 40% of all children in the United States are covered by Medicaid or CHIP, the Children's Health Insurance Program. So foundational reform of Medicaid, what it's going to do is take the financing of Medicaid out of both the federal government and the states and move it all to the feds. The states won't have any costs, any money they need to spend, unless they want to, on healthcare financing for children who qualify for Medicaid. This is a big deal. It moves politics. It opens the doors to lifetime, or at least for the first 26 years of free healthcare accessibility, hopefully, for all children who qualify for Medicaid. There are also, for the Academy, strategy and tactical challenges. For example, should we, the Academy, ask the board, go for the optimal at this time, or should we really, go for what the achievable is? The Academy has done a superb job at being able to discuss and promote things on both sides of the aisle because of our focus on children. The downside of this, if there is a downside, is that no child is an island. Something happens to parents or caregivers, it affects the children. But the Academy, at this point in political time, is going, I think very wisely to focus on Medicaid. Next slide, please. I won't go over this slide immediately. I want to lead into it a bit. This position by the American College of Physicians, called Better is Possible, is a landmark vision and policy statement, landmark on universal health care by the American College of Physicians. The college has 160,000 members. It is the largest primary care physician organization in the United States, and second only in size in terms of physician organization to the AMA. If we don't have time now, we might be able to visit this more in depth in our Q&A or in a possible overtime. Regardless, I strongly urge you to read this. I think it will not just open your eyes to what is possible, but I think it will do also, it'll lift your hopes and your heart. I know it certainly has done that for mine. Next page or slide. The Better is Possible statement in a full supplement to the Annals of Internal Medicine has this paragraph, which I've extracted. I'd like to read it now. It's brief. The U.S. healthcare system, the American College of Physicians says, is gravely ill, and the symptoms are many. The costs are too high. Many people lack affordable coverage. Incentives for hospitals and physicians are misaligned with patients' interests, and on and on. We've been over this, and it's recognized by the College of Physicians. Next slide. The goals of the ACP's vision for healthcare policy include universal coverage, improved access to care, reduced per capita healthcare costs, reduced rate of growth in spending, again, like Canada and other nations have been able to accomplish, reform clinician compensation. hello, pediatricians and internists and family practice docs and psychologists and psychiatrists, and to reduce the terrible, costly complexity of our healthcare system. Next slide. So the American College of Physicians has identified two financing options, methods of financing that they are confident will work. And they've looked at all of them. Out of all of their years of hard looking, two options emerged. One is the single payer, not-for-profit, publicly financed system. The other is a publicly financed model, like they have in so many countries in Europe and a few in the Far East, but with regulated private insurance. The insurers cannot put extractive, harmful prices on their insurance. Both of the above are very carefully defined and discussed in detail, with the upsides and downsides presented honestly and fairly in the American College of Physicians report. I do want to go into this. The report by the college has a call to action. And in it, they say, quote, the ACP rejects the view that the status quo is acceptable or that it's too politically difficult to achieve needed change. Dr. Atul Gawande wrote, better is possible. It does not take genius. It takes, diligence. It takes moral clarity. It takes ingenuity. And above all, it takes willingness to try, just to try. Close quote. Well, the college goes on to say, by articulating a new vision for healthcare, the ACP is showing a willingness to try to achieve a better U.S. healthcare system for all. And they close this paragraph with this phrase: we urge others to join us, just to join us. Next slide, please. This brings to mind one of my favorite quotes. Winston Churchill is alleged to have said it, probably apocryphally, but it's true. Says you can always count on the Americans to do the right thing after they've tried everything else. We're the only developed country. We're the last developed country to try universal, affordable, not-for-profit, publicly financed healthcare. Which brings me to this feeling that I have. What we do about this now. The ACP is calling everyone to at least join with them in discussion. What we do about all this now will have a profound impact on our personal and our professional lives, and that of our children. No child is an island. And that of our society and maybe the world for the rest of our lives. That's my feeling. And the themes that have woven through our talk today: everybody deserves health care. Many people, myself included, would say healthcare is a human right. No child is an island. Upstream, downstream. Look upstream to see what's and why it's happening downstream. And better is possible. Next slide, please. This is a list of resources, email list, readings and books, videos, advocacy organizations that you might want to take a look at. The Chapter 2, California, the Academy of Pediatrics will make this available to everybody. Next slide. I would urge you to check out these websites of Physicians for National Health Program, down here next, California Physicians Alliance, and the American College of Physicians, which issued this incredible Better for All, Better as Possible report. What many, including myself, are doing now is advocating for a publicly financed, not-for-profit, universal healthcare system. Sometimes it's called improved Medicare for all, single payer, whatever. It's got a lot of names. It doesn't make any difference what it's called. It's what values it incorporates and what attributes it creates. Let's talk more in the Q&A. Next slide. I want to express my appreciation to Doctors Grant Chrisman and Kamal Jones and Tomas Teresis, and to Will Barboza, all with the Chapter 2 of the Academy here in California, to Carol Foreman and Charles Tentindo for the videos, Miko Chino for her story, Nathan Gray for the comic strip illustration he made of Dr. Chino's story, Dr. Steve Tarzinski, a pediatrician, friend and colleague of mine, for the story that we had in his video, and to my colleagues, fellow advocates, and others, but also to all of you who have taken your time this evening to spend with us and look at this. I hope it's been worthwhile. I hope you can use it. And I really want to thank you for joining me and everybody else at this webinar. And my conflict of interest disclosures, contact information, you can reach me through the Academy. And finally, I want to say be well. Thank you, everybody. Thank you.
Thank you, Bob. Thank you so much for taking the time to walk us through this important and complex topic. And we really appreciate your efforts with that. This was super helpful and informative. I want to give folks, I know we are a bit past the hour. I want to give folks a chance to ask questions. I see Nancy Niparco with their hand raised. Nancy, go ahead.
Hi, Bob. Thank you so much. That was very good. I want to point out, I have a handful of favorite slides, but thank you for putting that one slide that put all the red checks and the blue checks and what you want out of insurance. I saw that was from you originated, and I think that really says it.
Thank you.
I want to point out,
don't know Nancy, she's a wonderful pediatric neurologist, friend and colleague of mine. Thanks for joining us, Nancy.
And I like to remind people that in the early 1990s, when you had more experience than I had, and I was starting out, there was a lot of criticism of physicians for not understanding business. From many sources, I heard statements that they should give business courses in medical school, like we didn't even have enough to learn back then. Yeah. Well, I like to say the world, you got what you asked for. Medicine is turned into a business. And I just finished a vacation on which I picked up a book about Amazon. I'm glad you mentioned Amazon.
Yeah.
Amazon is absolutely a monopoly that's starting from advertising, who can advertise, pushing advertisers out, making their own product, doing it all. You've heard the horrors of their warehouses and all the way they control deliveries and getting into medicine.
Yeah.
And there used to be laws that are now not enforced about monopolies.
Yeah.
And I don't think you can do this part-time. I think we need single payer 100%, because if we give them an inch of saying, okay, we'll allow you this much profit, it's never going to work. And it just makes me furious that it's that they squeezed us in the 90s. And I understand that you may not need a nurse for every single patient on the floor, but getting down to 6 or 8 patients per nurse is absurd. We've been squeezed as far as we can be.
Yeah.
And let me say one more thing. This is pretty funny. And you were right there. And when Cedars-Sinai put together their own HMO, which was partly owned by physicians that were there. And I was called up the guy because I was the new person taking all the Medi-Cal, and I didn't care. I was happy to be so busy. I was busy, but I was taking all the no or little insurance. And I called up the head and I said, how can you reduce the reimbursement so low? And I said, I can't pay all my bills with this. And he said, well, you make it up for with the people who have the good insurance. And I said, but what if I'm seeing all the people who have Medi-Cal? I actually made him speechless. I was very proud of that moment.
Yes. Thank you.
We're all there now. Thank you.
Yeah, sure.
Thanks, Nancy. Does anybody else have any comments or questions for Bob? Bob, I do have one question. Having had a career doing this in the way that you have, seeing the challenges that have come with people over the years trying to implement such a program, such a single payer, what gives you hope when you look at the path ahead?
What did I hope when, at what point?
What gives you hope as far as our ability to achieve this when you look at the path ahead?
I strongly believe it's going to happen. I just don't know when. It's like the weather used to be in the past. It's pretty hard to predict. We've gotten much, much closer to it now in terms of public awareness than we've been for a long time. However, the forces, the profit-making mega corporation forces are spending a huge amount of money lobbying Congress, because unless the federal government gives waivers for states that are large, such as California, to implement a universal health care plan, it's going to have to be done at the federal level. The waivers are possible way to go. But I may be off on this in precise numbers, but the big pharma, I think, is employing over 1,000, maybe 1,200 lobbyists or more in Washington, D.C. to lobby Congress, the Senate, and the House, and everybody connected with them to keep the system that we have so that they can charge huge extractive profits and make insulin cost like it used to. There are changes now. Insulin was made in developed in the mid 1930s. So it's not a new medicine exactly. But the pharmaceutical companies were able to monopolize things and raise prices astronomically up to $300-400 or more dollars, for a month's supply. Biden managed to get that cost down for a lot of people down to no more than $15 a month in the last few months. But those lobbyists are giving a lot of money to senators, legislators. Basically they're buying profits for themselves. That's got to stop. People, I think, are going to really get angry as they know that their friends and relatives, people that they love and care for, are dying because of lobbying, both by big pharma, by the insurance companies, by other private equity investor groups that are now really starting to invade and extract our healthcare dollars.
Thank you.
Yeah.
Okay, so we are out of time, but I want to thank you so much again, Bob. Thank you everybody for joining us and for taking time out of your evening to be here. And to Bob's point, I hope that this was fruitful for folks. And if you have further questions, we will be sending out Bob's contact information, and the slides will be accessible as well. Dr. Bob Vinetz, thank you. Have a good evening, everybody.